All right, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's topic is a rich one, and it's one that is... If I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. Really important, depending on what kind of ICU medicine you do, but I suppose if you do any, or if you just have a nerdy love for hemodynamics like we do, and that is pulmonary artery catheters, also known as the Swan-Ganz catheter. We're going to be diving into all things PACs. We'll start by talking about what it is and what it measures. We'll talk about the different ports, thermodilution, cardiac output, normal values for all the different heart chambers, when to use a pulmonary artery catheter, situations where maybe you shouldn't be using it, contraindications, cautions. We'll talk about how to place it, how to set it up, the waveforms, how to confirm it, what you can calculate using your pulmonary artery catheter. Some framework for thinking about the different values and what pathologies they might point to, benefits, limitations, and pitfalls, different trials, practical pearls. We have a little kind of cheat sheet, pocket cheat sheet for the bedside, and then we'll do some practice questions. This is a really intensive, detail-focused episode with lots of information. So we'd highly encourage you all to consider checking out our Patreon page where we upload this study guide here, because this is going to be something that you're going to probably have to revisit. It could even be something that's useful to have with you at the bedside, or a picture of it on your phone or something, because there's going to be a lot of numbers and detail that might be hard to remember right off the bat. So this will be on our Patreon page, which is linked in the episode description, if you have an interest in accessing it. So we put all of our study guides and ad-free videos and practice questions and all that jazz. But no further ado, pulmonary artery catheters, or PACs. So what is a pulmonary artery catheter? Well, this is a multi-lumen flow-directed catheter that usually is advanced from a central vein. Oftentimes you use the right internal jugular or the subclavian veins. Under fluoroscopy, you can do a femoral vein as well, although that's much harder to do bedside. And it's advanced through that vein into the right heart, into the right atrium, past the tricuspid valve, into the right ventricle, and eventually into a branch of the pulmonary artery. You float it, which we'll get into more, using a balloon through those heart chambers into that pulmonary artery, hence pulmonary artery catheter, PAC. It has a small balloon at the tip, which is what you inflate when you're floating it, and then that balloon can actually wedge the catheter in a distal portion of the pulmonary artery, right? You have a pulmonary artery, you have your catheter with a balloon on it, and as you advance it, if that pulmonary artery, as it gets smaller and smaller, that balloon will eventually wedge in that pulmonary artery, and there's a portion of the catheter on the other side of the balloon that then can transduce pressure on the other side of that pulmonary artery, which we'll talk about what that means, because it helps you estimate the left-sided filling pressures, right? Those left atrial pressures. Again, we'll get into that more. So the key kind of ports and things to think about to understand how this catheter works is there's a couple different ports. Okay, one of those ports is the proximal port, and that port sits in the right atrium. And you can transduce pressures off that port to get a right atrial pressure or a central venous pressure. And you also inject things into that port to do thermodilution to calculate a cardiac output. Again, we're just introducing these topics here. We'll talk more about them. So one of the ports sits in the right atrium. So as that catheter, the tip sits in the pulmonary artery, one of the ports within that catheter stays in the right atrium, where you can get a right atrial pressure and also inject to thermodilute to get a cardiac output. There's then what we talked about, the distal port, the one that sits in the pulmonary artery. And this port can give you the pulmonary artery systolic, diastolic, and mean pressures when the balloon is deflated. Okay, so the balloon is deflated and the end of that catheter is just sitting in the pulmonary artery, which is why you can transduce a pressure from it and get a systolic and diastolic pulmonary artery pressure. You also can pull a venous blood gas off of it, which gives you a true mixed venous saturation, because that is the last part of the venous system before it goes through the lungs and gets oxygenated. So it's a true SvO₂, a true mixed venous saturation. All right. We sometimes get kind of a surrogate mixed venous, an SvO₂, off a central line that sits at the cavo-atrial junction. But you need a pulmonary artery catheter sitting in the pulmonary artery to get a true mixed venous. And then if you inflate the balloon, you can get what's called a pulmonary artery occlusion pressure, PAOP, also known, complete synonym, with a pulmonary capillary wedge pressure, a PCWP. And what this is, as we talked about, is you're occluding that pulmonary artery. And then there's the tip of the catheter on the other side of the balloon. And that tip you transduce a pressure off of, and the pressure you're experiencing, because you've occluded that blood vessel, there's no blood going from the right heart past the balloon, it's completely occluded. So the pressure that sensor is reading is actually the left atrial pressure transduced backwards to the catheter, right? It's a left atrial pressure surrogate. When certain conditions are met, which we'll talk more about. So you have a proximal port that sits in the right atrium that can give you a right atrial pressure. You have a distal port that sits in the pulmonary artery that can give you a pulmonary artery pressure. And then if you inflate the balloon and cut blood flow off through that vessel, you can get a surrogate left atrial pressure. And then the last thing here, which we've kind of hinted at, is you can actually get a cardiac output measurement by thermodilution, using this device called the thermistor, okay? And that can give you a surrogate for the cardiac output. You can also, have the FIC equation, which we've talked about on the channel before. Definitely check that out. Just search Whiteboard Medicine FIC, and it'll come up. You can use the FIC equation to calculate the cardiac output as well. So this is a very kind of versatile and gives you a lot of different hemodynamic numbers type of catheter. It's probably, we're going to think about this before we say it, but it's probably the most intensive invasive monitoring device you can have, because it can give you so many different heart chamber pressures that can be incredibly helpful, especially in patients with mixed shock or undifferentiated shock or cardiogenic shock. So the typical normal values, this is where we're going to get into some of the numbers, and this is where probably having this study guide on our Patreon page will be super helpful, okay? So these are the typical normal values. As we said, you can get a right atrial pressure, and a normal right atrial pressure, this is the CVP-ish, is 2 to 8 millimeters of mercury. You can get a right ventricular pressure on this catheter too, and the normal right ventricular pressure is 15 to 30 over 2 to 8, right? Because there's a systolic and a diastolic. And I'm not going to spend too much time. I'm just going to read off these pressures because, again, these are things you're probably going to have to revisit and reference. You can then get a pulmonary artery pressure, right? We said the tip of the catheter is sitting in the pulmonary artery, so you can transduce a pressure there. And that normal is 15 to 30 over 8 to 15 with a mean of 10 to 20. Now, some accept less than 20 depending on the context, but normal mean is 10 to 20. And then you can inflate the balloon and get a pulmonary artery occlusion pressure, also known as a pulmonary capillary wedge pressure, which is a surrogate for left atrial pressure. And the normal there is 6 to 12. We're going to talk about what it means when some of these are abnormal. Then we said we can draw venous blood gas off it and get a true mixed venous, an SvO₂, normal being 60 to 80%. And we can either use thermodilution or the FIC equation to calculate the cardiac output and cardiac index, with a normal cardiac output being 4 to 8 liters per minute, and a cardiac index, which is essentially the cardiac output as calculated based on the surface area of the patient, a normal cardiac index of 2.5 to 4. So these are all the normal values that you can calculate and get off. Let's change that. These are the normal values that you can get directly off the pulmonary artery catheter, because we're going to be talking about a bunch of equations you can do to calculate different values as well. So these are ones you can physically measure off the pulmonary artery catheter. All right, so when to use it? Well, we wrote here choose selectively. And we have mixed feelings about this phrase, but the summary here is that, when people have actually studied the use of pulmonary artery catheters, many of the studies have shown no improved outcomes just in all comers. But people who are critical of that, people who are very pro pulmonary artery catheter, would argue that, if those studies were with folks who maybe didn't know how to use the pulmonary artery catheter most appropriately. But Again, choose selectively. There does seem to be patient populations that benefit more than others, okay? So when considering when to use a pulmonary artery catheter, think about when non-invasive or less invasive tools are insufficient, right? Your management hinges on precise hemodynamics. You're having trouble understanding what's going on. And this might be in refractory, complex, or mixed shock, right? Maybe someone's septic, but their EF at baseline is 10%, right? That might be a patient where being unable to understand what the right atrial pressure is, what the right ventricular and pulmonary artery pressures are, what the wedge pressure is, what the SvO₂ and cardiac index is. That might be a patient where that's really important, right? Someone with a normal heart who's septic, they're able to compensate. They're able to increase their contractility and cardiac output to compensate. But someone who's septic with a bad heart might not be able to compensate. Or someone who's septic who develops sepsis-induced cardiomyopathy, right? All these patients might benefit from it, these refractory, complex, or mixed shock states, especially when therapies are escalating and they're getting worse, and you really want a better idea. What are my filling pressures? What's my cardiac index? What's my SvO₂? And I can calculate things like SVR and PVR, which we'll talk more about. Advanced heart failure, this is a classical patient population, right? Patients who are kind of advanced heart failure, cardiogenic shock-esque. It's hard to know their volume status, their afterload. Is it RV failure? Is it bi-V failure? Maybe you're evaluating them for a LVAD, which we've talked about on the channel, or a heart transplant. This is a very classical population. Pulmonary hypertension, RV failure, is also a very classic population where pulmonary artery catheters can be helpful because we can actually quantify their pulmonary vascular resistance, or their PVR, which we'll talk more about, and that can help us guide things like pulmonary vasodilators or inotropes. Post-cardiac surgery, most of these patients have pulmonary artery catheters. And then select major non-cardiac surgeries, right? In patients with severe cardiopulmonary disease, sometimes liver transplants, right, have a pulmonary artery catheter coming out of the operating room. So some non-cardiac post-operative patients can benefit. But I'd say the most common is advanced heart failure and cardiogenic shock, as well as pulmonary hypertension. Next most common is probably cardiac surgery and non-cardiac surgery, and then after that is probably refractory or complex shock states. All right, so situations where it's rarely helpful, you know, if you have a patient who's doing okay, they're hemodynamically stable, or they have classic sepsis without any kind of complex cardiac problems, or you're able to get good echo windows, or you have other ways to monitor the patient that are effective, you know, those patients probably don't need a pulmonary artery catheter. There are some complications that can happen, which we'll talk more about. Contraindications to placing the catheter itself. Well, as with anything, there are absolute contraindications and relative contraindications. Some of the absolute ones are things like a right-sided endocardial mass. As we talked about, those listening, I'm a terrible drawer, but just know that I'm drawing a heart. Right atrium, right ventricle, left atrium, left ventricle. Here's the SVC. Here's the IVC. You're threading this catheter through the SVC into the right atrium, through the tricuspid valve, into the right ventricle, and then we'll kind of do pulmonary artery into the pulmonary artery. So you have to go through this whole right side of the heart. If they have a big right-sided endocardial mass, or a thrombus, or a vegetation, or a mechanical tricuspid valve, or what have you, pathology on the right side of the heart can make this procedure quite dangerous because you have to float through there blindly if you're not doing it with imaging guidance. And then relative contraindication, severe coagulopathy. You know, these are big catheters. You have to put in kind of a big MAC introducer sheet that is quite large and can cause bleeding. Endocarditis, left bundle branch block is one people talk about. It's a relative contraindication. But the thought here is if you have a left bundle branch block, right, you have, if we go back up to the drawing, again, those listening, we're terrible at drawing, so it's probably not helpful. But you have the SA node, you have the AV node, then you have kind of your signaling cascade through the atrium. Then you go through the His into your left and right bundles. If you have a left bundle branch block, the concern is putting a catheter through the right side of the heart can maybe cause a right bundle branch block that can then decompensate to complete heart block. Relative contraindication. And then recent right ventricular infarct or irritability, with the thought being that you're going to irritate the right heart into an arrhythmia. So those would be relative contraindications. So how to place the catheter itself? Well, what should we tend to do is a waveform guided placement at the bedside. You know, you can do it under fluoroscopy. We're going to be talking about waveform guided placement. So you need an introducer sheath. Right, this is the catheter actually goes in the vein that you then float the pulmonary artery catheter through. So you need an introducer sheath. You'll flush all the lumens. You'll calibrate it at the phlebistatic access fourth intercostal space mid-axillary line, similar to zeroing for things like CVP. And then this, many people will attach continuous EKG leads. If we're being honest, again, this is never intended to be acted upon medical advice. Please check out the disclaimers in the episode description or at the end of the episode. But we don't tend to do the continuous EKG lead. We focus very much on the waveform. So while doing that, what happens is you're going to, obviously you got your introducer sheath in. Now you've inserted the actual pulmonary artery catheter, which is different than the introducer sheath. So you've inserted the pulmonary artery catheter, you're advancing it through the introducer sheath, and most people go to like 15 centimeters. Then you pause. You inflate the balloon. The balloon inflates with 1.5 cc's. Most of them have a syringe specific to it that only has 1.5 cc's. So you can't put more than that in there, but just make sure you use that syringe from the kit. And, we can't say for certainty every kit has only 1.5 cc syringes, but most of them probably do. But keep an eye on that. So at 15 centimeters, you inflate the balloon, and then that's when you start floating and watching the waveform. So what'll happen, and we'll get into the waveform itself, but as you're slowly floating it, going little by little, if you could do it with heartbeats, great, a little centimeter at a time, you're watching the waveform. And you get into the right atrium, you see that waveform, you keep advancing, you get into the right ventricle, which is where you get this rise in systolic, but the diastolic stays near zero, and then you're still floating until you get into the PA, which is where the diastolic rises. And then you keep floating until you wedge, which is when the venous waveform resembles the left atrium. And that's where you will deflate the balloon. You never, ever pull the balloon, pull the catheter back while inflated. So, pictures worth 1,000 words. This is an image from Summerhill, Baram et al. Called Pulmonary Artery Catheterization in the Critically Ill, published in Chest in 2005. It's their work, not ours. We appreciate it, and definitely check out their original trial. But this is what it looks like. So you're inserting the catheter 15 centimeters, inflating the balloon, and then slowly floating. And you'll first see this right atrium waveform. Okay, it's kind of that quote-unquote CVP waveform. As you keep advancing, you'll see this huge systolic shoot up, which is the right ventricle, right? And that means you are now past the tricuspid valve into the right ventricle. And as you keep advancing, you'll then see this kind of diastolic step up. The systolic pressure will stay the same, but the diastolic pressure will jump up. And that's when you're in the pulmonary artery. That's when you know you're close to being wedged. And then once you wedge, you'll see that systolic drop way down. You'll kind of get this wedge waveform, which, it's not totally flat. Make no mistake. This isn't just some flat waveform. You still have AV waves and all that, but it's left atrium. So it's similar to right atrium, but just those pressures are higher in general. So that's what it'll look like when you get wedged. And when you wedge, you want to stop, right? That means you're wedged. You want to keep pushing. You keep pushing, could rupture a pulmonary artery. So this is when you're wedged. Record all your numbers, deflate that balloon. Never pull the catheter back, never pull the pulmonary artery catheter back with the balloon inflated. And we always recommend, closed loop communication. Say, put the balloon up, and then someone says, balloon is up. Put the balloon down, the balloon is down. All that closed loop communication stuff is important. So confirmation and safety. You're going to target zone 3 placement, and you want to measure at the end of expiration, especially if you're on mechanical ventilation. Use a chest x-ray to confirm the tip is in the proximal pulmonary artery. You do not want it too distal because there'd be increased risk of rupture. Label your lumens. Depth, the classical depth to wedge is somewhere around 45 to 55 centimeters. So remember, we said we insert it to 15 centimeters, then inflate the balloon, and then you're slowly advancing it, watching the waveforms, and it usually takes to about 45 or 55 centimeters before you will actually wedge. This varies by patient. Sometimes it might be less, sometimes it might be more, but that's just kind of a rough estimate of where you might get wedged. So what other cool stuff can you do with your numbers? What calculations can you do? How to use those calculations? Well, again, this is going to be a lot of numbers and equations, which is why is not to keep beating the drum here, but this will be on our Patreon page, so definitely go check it out and print it out because these are going to be hard to remember. But the first thing, cardiac output. Using thermodilution, you can actually get the cardiac output, how much the heart is pumping out, which is awesome, right? And then from that, you can derive the cardiac index, which is just the cardiac output divided by the body surface area. You can also calculate the stroke volume, which is just the cardiac output divided by the heart rate. You can calculate systemic vascular resistance, which is super helpful, right? Low systemic vascular resistance states might be septic. High systemic vascular resistance states can be cardiogenic or obstructive or hemorrhagic. So this can be super helpful in understanding the shock state you're dealing with. And the SVR is going to be 80 times your MAP minus your right atrial pressure. So we can get the MAP off their blood pressure. We can get the right atrial pressure off the pulmonary artery catheter, divided by your cardiac output, which the pulmonary artery catheter can calculate using thermodilution or the Fick equation. You can also get the pulmonary vascular resistance, similar to the systemic vascular resistance, except this is the pulmonary vasculature. And this can be very helpful with diagnosis of pulmonary hypertension, titrating pulmonary vasodilators and all that kind of stuff. And that equation is the mean pulmonary artery pressure minus the pulmonary artery occlusion pressure, also known as the pulmonary capillary wedge pressure, divided by cardiac output times 80. Again, all things you can get off the pulmonary artery catheter, right? The pulmonary capillary wedge pressure is that pressure you get when you inflate the balloon and wedge. The mean pulmonary artery pressure is the mean of the pulmonary artery systolic and diastolic, which you can get off the catheter. And then cardiac output you can get using thermodilution or Fick. And then the SvO₂ we talked about can be helpful. The venous blood gas you can draw off the pulmonary artery catheter in understanding kind of your perfusion in different shock states. So we wanted to provide a little kind of framework for how these numbers can help you. And again, this is complex, but we wanted to at least introduce it here. So an interpretive framework, kind of pattern recognition. So think about this as we say it out loud. So if you have a high right atrial pressure, you have a high pulmonary artery occlusion pressure, also known as pulmonary capillary wedge pressure, and a low cardiac index. So high filling pressures, high afterload, low cardiac index. That's indicative of something like biventricular failure. If you have a high right atrial pressure, a normal wedge pressure, a low cardiac index, and a high pulmonary vascular resistance, that indicates right ventricular failure or pulmonary hypertension, right? Because your wedge pressure, your left side of your heart's okay, but your pulmonary vascular resistance is high, your right atrial pressure is high, and your cardiac index is low, indicating the right heart is struggling. If you have a low right atrial pressure, a low wedge pressure, and a low cardiac index, that can apply hypovolemia, right? Your right atrial pressure is low, your wedge pressure is low, and your heart cardiac index is low because it doesn't have enough filling to pump blood out. If you have a low right atrial pressure, a low wedge pressure, and a high cardiac index, that usually implies like septic shock, vasodilatory shock, because you have low filling pressures, but your cardiac output's chugging away. It's high. It's kind of hyperdynamic. And then if you have a high PA diastolic pressure with a normal wedge pressure, that can just imply increased pulmonary vascular resistance, which can be things like ARDS, PE, hypoxemia can cause high pulmonary vascular resistance, acidosis, all that stuff. So these are kind of advanced, and we didn't want to, all these could be a video in and of itself or a episode in and of itself, but we at least wanted to kind of demonstrate how you can use these numbers to better understand different shock states. All right, what are the benefits? Well, obviously you can get a much more comprehensive hemodynamic profile using one device. You can get a preload, afterload, cardiac index, SvO₂, PVR, SVR, all that kind of stuff. Real-time trending and monitoring, right? This catheter stays in, so you're seeing how it's changing with your interventions, with pressors and inotropes and diuretics and vasodilators and pulmonary vasodilators, you know, and you're seeing, is it getting better? Is it getting worse? And it's objective data for things like LVAD and transplant candidacy, pulmonary hypertension, vasoreactivity testing, right? All this objective data can be really helpful for patients with sick hearts, seeing what they're a candidate for in terms of advanced therapies. And then it can clarify mixed shock states, as we said. It can tell you filling pressures on the right side, the left side, cardiac index, pulmonary vascular resistance, systemic vascular resistance, et cetera, et cetera. So it can help you understand mixed shock states and what you might be able to do to best optimize that patient's oxygen delivery. Limitations and pitfalls, though, when they've studied it, as we said, no proven mortality benefit in a broad ICU population, and it's a procedure, so there are complications that can happen. You can rupture a pulmonary artery. As you can imagine, that's very bad. There can be bleeding, infection, clots, damage to the right side of the heart, arrhythmias, damage to the tricuspid valve. All these things can be really serious. So don't just use it indiscriminately, but there is benefit in certain populations, so don't be afraid to use it. Other limitations, the pulmonary capillary wedge pressure is not perfectly, this is going to be a more advanced statement, but is not perfectly synonymous with the left ventricular end diastolic pressure under many conditions, right? So when you wedge, you're saying, oh, that's the left-sided pressures. And sometimes that's true, other times it isn't. Times it isn't is if you have mitral valve disease, if you have pulmonary venous disease, elevated PEEP, you're not in correct positioning. So it's still not perfect. You still have to take it with a grain of salt and understand when it might be inaccurate. Over-wedging, right, means you are wedged and you're still advancing the catheter. You can rupture the PA, and that has a very high mortality, right? So this is not a benign procedure. You can cause arrhythmias. You can also entangle in valves and stuff. And then measurement errors. You want to do the measurements at end expiration. Otherwise, it'll be inaccurate. If there's a lot of PEEP, it can be inaccurate. If you're an AFib, it's sometimes inaccurate. There can be kind of catheter whip, which can dampen the waveforms. Thermodilution errors in the setting of high or low tidal volumes and cardiac shunts and tricuspid regurg. So again, all these details to say this isn't perfect. And we need to understand when it's most accurate and when it might not be accurate. Evidence to know for those big nerds out there like me, we listed a handful of trials: ESCAPE, PAC-Man, Sandham et al., and the FACTT trial. And this is all to say that many of the trials out there don't have a big mortality benefit, but do know that it's really hard to prove mortality in the critical care literature, right? We put in central lines all the time. Has there been a study that has shown a mortality benefit from central lines? Not that we're aware of. Same thing with A-lines, not that we're aware of. Same things with a lot of interventions. So that's not to say that pulmonary artery catheters don't help patients. It is to say, though, that it doesn't just by doing it in everybody without really knowing what you're doing or how you're going to use it or being selective with the right patients, it probably is not helpful just doing it to everyone. And it's ridiculous that we have to say that out loud, but that's more what these mean, right? So be selective, be thoughtful, know what you're going to do with it and how you're going to use it, and make sure you have an indication that you think it'll be helpful for before you do it. So a couple practice pearls. Just in general, as we said, measure your pressures at the end of expiration. That's when they'll be the most accurate. PEEP higher than 10 or 15 may throw off your numbers. Confirm the wedge by waveform and x-ray position and make sure you always deflate the balloon afterwards. Never leave the balloon up. In pulmonary hypertension RV failure, think about your right atrial pulmonary vascular resistance and PA diastolics to optimize things. And then peripulmonary artery catheter with things like echocardiogram, they're complementary. They can both be helpful. And always ask, will this number change what I do today? If not, you probably don't need the pulmonary artery catheter, right? Another example of just being selective. So here's kind of a mini table, kind of a little pocket handbook on normal right atrial pressure, mean pulmonary artery pressures, pulmonary capillary wedge, cardiac output, cardiac index, SvO₂, SVR, PVR. We won't read it all out loud again, but this is helpful, again, if you want to access the study guide. And then here's some derived formulas. All right, that was a whirlwind. We hope that was helpful. It was a lot of detail. Let us know if that was just too much detail and not helpful because of it. Let us know in the comments, and that way we can further advance the knowledge around this in a different way in the future. All we have left are 3 practice questions. For those of you who have not participated in practice questions at the end of one of our episodes, because it is at the end, so who knows how many people end up making it to the end. The way we do it is we'll read the question, read the answer options, and then we just dive right into the answer. So if you need more time to think about it, just make sure you pause because we'll just dive right into the answer afterwards. All right, we need a sip of our drink to rehydrate. All right, let's go. Question 1. There will be a beginner, an intermediate, and an advanced question. Question 1 is the beginner question. A ventilated patient has a right atrial pressure of 3, a mean pulmonary artery pressure of 16, a pulmonary artery occlusion pressure, also known as the wedge pressure, of 5, a cardiac output of 3, a MAP of 60, and an SvO₂ of 54%. What is the most likely shock pattern? Although this is the beginner question, these are advanced devices, so these questions are a little kind of higher level just to start with. But what's the most likely shock pattern? Pause here if you need more time. The correct answer is B, hypovolemic shock. And the reason being is you have a low right atrial pressure of 3, a low pulmonary capillary wedge pressure of 5, and a low cardiac output. So when all 3 are low, that is most consistent with hypovolemic shock? Oh, did we even read the answer options? A, cardiogenic shock, B, hypovolemic shock, C, septic shock, and D, obstructive shock. So in cardiogenic shock, you'd expect a high right atrial pressure and a high pulmonary capillary wedge pressure with a low cardiac output. In septic shock, you expect a low right atrial pressure, a low pulmonary capillary wedge pressure, but actually a high cardiac output because they're hyperdynamic. In an obstructive shock, it'd be a high right atrial pressure, potentially a normal pulmonary capillary wedge pressure, depending, and then a low cardiac output. So this one would be hypovolemic shock because all three are low: the wedge, the right atrial, and the cardiac output. All right, next question is intermediate. You're measuring the pulmonary capillary wedge pressure in an ARDS patient on a PEEP of 15. The wedge at end expiration is 16 millimeters of mercury, and that's in the setting of a mean pulmonary artery pressure of 32, a right atrial pressure of 12, a cardiac output of 4.5. The chest x-ray shows the pulmonary artery catheter tip somewhat distal. Which is the most appropriate next step? A, interpret the pulmonary capillary wedge pressure directly as left atrial pressure and restrict fluids. B, deflate the balloon and reposition the catheter to confirm zone 3 placement. C, increase the PEEP to improve accuracy of the pulmonary capillary wedge pressure readings. Or D, remove the pulmonary artery catheter as it has no role in ARDS management. All right, pause here if you need to. The correct answer is B, deflate the balloon and reposition the catheter to confirm zone 3 placement. So high PEEP and distal placement of the catheter can artifactually elevate the pulmonary capillary wedge pressure. And beyond that, you always want to make sure you have optimal zone 3 placement, which we didn't really dive into zone 3 placement too much. Maybe we'll do a separate episode on that if you have questions. But the summary here is you always want it in the appropriately placed position before you trust the readings of it. Okay, so correct answer is B. All right, last is the advanced question. A patient with mixed shock has a right atrial pressure of 15, pulmonary artery pressure of 48/26, pulmonary capillary wedge pressure of 14, cardiac output of 2.2, MAP of 58, SvO₂ of 48%. Which calculation is most helpful and what does it indicate? A, SVR is most helpful, and it indicates that the SVR is low, suggesting distributive shock. B, pulmonary vascular resistance is most helpful, and it is high, suggesting pulmonary vascular disease. C, pulmonary capillary wedge pressure directly is most helpful, and it's elevated, suggesting isolated LV failure. Or D, the right atrial pressure to pulmonary artery pressure ratio is most helpful, and it's low, suggesting the isolated RV failure. All right, this is a tough one. You probably have to do a bunch of math. The correct answer is B. So in this patient, their pulmonary vascular resistance, if you do the math, is quite high. And that suggests pulmonary vascular disease, especially when it's markedly elevated. And this can imply RV strain, especially if the pulmonary capillary wedge pressure is normal. That suggests isolated RV disease. And what you'll see is the right atrial pressure will be high as well. The pulmonary artery pressure will be high. The pulmonary vascular resistance will be high. And the SvO₂ will usually be low. So this normal pulmonary capillary wedge pressure in the setting of these other findings suggests RV strain from pulmonary vascular resistance, which can be pulmonary hypertension or ARDS or PE or what have you. All right. I know that was a whirlwind. Appreciate those that have stuck till the end. Hopefully it was helpful. Hopefully it can be a good reference in the future. Let us know what thoughts, comments, questions you have down below. Check out our Patreon page, YouTube platform, podcast platform. And nonetheless, we appreciate you all. Stay well, keep learning. We hope to see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.